You're watching a special edition of the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. My first guest is Dr. Greg Keller. Dr. Keller is internationally recognized by his peers as a master for his unique and innovative contributions to facial plastic surgery. Dr. Keller is a Castle Connolly rated top doctor, an honor bestowed on only a few physicians nationwide by peer selection. This year, he was selected by Strathmore's Who's Who as the #1 top professional in facial plastic surgery in the country. His contributions include 2 textbooks and over 25 medical peer-reviewed articles in facial aesthetic surgery and laser technologies. As a single contribution, Dr. Keller is the inventor of endoscopic facial plastic surgery and holds 3 patents for these techniques. Dr. Keller is honored to hold the title of Director of Facial Plastic Surgery at the Fellowship at UCLA. He has discussed his techniques and innovations on Good Morning America, Discovery Health, KBC, Extra, and E, and many others. His patients include many well-known actors and actresses, studio heads, corporate executives, billionaires, inventors, authors, and other personalities. His patients come from India, England, Canada, Korea, France, and all over the world. We've invited Dr. Keller on the program today to discuss new mini facelifting techniques. Dr. Keller, welcome to the program.
It's a pleasure to be here, Randy.
Now today we wanted to get more into the technical part of the facelift. You know, we get emails and people want to know, okay, how are they doing it? Where do you hide the scars? Is it endoscopic brow lift, coronal lift? Am I saying that right?
That's correct.
And you know, what deep plane facelift versus some of these other, you know, mini lifts, what you're actually doing to the neck, and blepharoplasty, how you avoid that, I guess, skeletal look. So this is all about the technical stuff. And I guess some people don't want to hear this stuff. This is some of the gore. So, you know, I mean, do you find that people don't necessarily want to know how it's done, they just want a great result?
Well, there are 2 types of people.
Okay.
One group wants to learn everything about it, and the other group doesn't want to hear about it at all.
Right. I'm that group. I don't really want to hear what you're doing.
Right.
Right. Right. Okay. Yeah, I mean, some people, I guess they just want to look at your before and afters, get a feel for you, and that's it. Some people, I mean, do they really want to know what you're doing?
2 different groups of people again. Some do, some don't.
Okay.
And I think that you have to meet everybody's needs when you talk to them, because communication is everything in this field.
Okay, so let's start then with the aging face, the eyes. We'll start with the eyes. And we'll start with the brows. What are you doing now, and what are the different techniques? And then we'll move, I guess, to the eyelids, under the eyes, and down the face.
Well, there's several different techniques for the brow. Let's go from the top down. And the goal, of course, is to put the brow in its natural position, not overdo it, not underdo it, and to fill volume. So what we're doing currently is entirely endoscopic. I've been doing endoscopic for so long that I can do as good or better a job endoscopically than I can open. The old open techniques made an incision all the way across and down, folded everything down, and lifted it back up there.
And they still do this today.
It's still done today.
A lot of my plastic surgery friends do it that way, and they say because endoscopically the brow falls. What do you say to that?
You know, all I can say is coronally it falls, but we have now we do have 20-year follow-up, and ours are still up.
Have you done thousands of brow lifts?
I have.
Is that right?
Yeah.
I mean, you invented the endoscopic brow
well,
lift.
for the first, you know, from about 89 through 93 or 4, I had the field to myself, so we did a tremendous number in that.
Because you were the only guy doing it?
I was at the time, yeah.
Okay.
Yeah.
Now tell me about technique. Because you say to me, Randy, you got to be careful. You know, brows of an 18-year-old are not high. Explain that.
Well, what we want to do is make an arch to the brow that's a little higher, you know, on the outside than it is on the inside.
Is that the way a young person's
That's why young people look out, and they have some volume to the brow, and you know the brow isn't overdone, and they have a nice eyelid that you can see, and that a woman can put makeup on for the most part. But not everybody have that, so I like to bring pictures in. Now, when the coronal brow lifts were done doing this, you can do a very good job that way. One of the disadvantages is it tends to pull the hairline back all the way across. And, you know, while the incision's well hidden...
It makes your forehead bigger?
It makes your forehead a lot bigger.
Really?
Yeah, and the other thing is you're taking out hair in the middle here, and the hair in front is thinner, so people perceive their hair, that they lost hair, but what they've actually done is move thinner hair back.
They've gained forehead.
In a coronal lift. Now,
Yeah.
they're what are called pretrichial
Now
lifts.
this is, and by the way, I've been doing enough of these interviews where this is exciting to me. This is interesting because I didn't know. I've never heard that stuff before.
Okay.
Okay.
Well, pretrichial lifts are where you make an incision in front that then comes back, and you can actually lower the brow. The problem is in this area, you're bringing this thinner hair back again so that it looks like your temporal or the temple here recesses the hair there.
Okay.
And that you're losing hair in this area. So women will think that about that, even though in front here that hasn't been the case. So that's the problem with that, and the fact that
That
you have
sounds
a
like
scar
a big
across.
problem, though. By the way,
It
because
can
sometimes
be.
you look at somebody's face and you know something's wrong.
Yeah.
And if you made their forehead bigger or given them even a slight receding hairline, I could see where that would not look so great.
Well, different strokes for different
Okay,
folks because
okay.
there are advantages and disadvantages, but those are the problems with that. Now, when we do endoscopic type of techniques, we still lift the forehead, but only a couple of millimeters because our
Oh, it's
pull
slight,
is,
okay.
yeah, our support is largely from
And
this
where are
area.
you going in, by the way?
Well, we make little incisions in the part line all along the top of the head, 2 or 3, and then a couple little incisions, but they're real tiny.
And so what are you putting in there? A little scope?
We put an endoscope in, much like you'd do with a knee or take a gallbladder out through an
Okay.
endoscope, telescope. Quicker recovery, better healing. If we need to lower the forehead, we'll make a little tiny incision here and just bring the front down a little.
So what are you doing, by the way, to achieve this brow lift? I mean, there's muscles covering the forehead. You're just picking them up. What are you doing?
We're actually shifting the forehead backwards for the most part. And there's an agonist-antagonist relationship between the muscles. There are muscles here, big strong muscles that work with gravity and pull the brow down.
Okay.
And then there are thin muscles that pull the brow up, the frontalis muscle. These are the corrugators procerus. And these muscles win because they pull with gravity, they're strong. These muscles lose, they're thin muscles that support the brow upward. So by weakening these muscles, we allow these muscles to pull the brow up, but we also shift the lining of the bone up and stabilize that in very specialized ways. And I've been through every way that you can think of, and I think we're pretty successful at it because we allow the lining of the bone to adhere nicely and give a lot of support to that brow, so it stays up. And then we can take little pieces of fat and other things and add some volume to the brow at the same time, or take a little strip of skin. And when we take that strip of skin, we want to be very specific about how we take it.
Okay, now when you teach, doctors, MDs, when they're learning this, they go, you teach doctors from all over the country. What is your main message to them to ensure a natural look? I mean, what could go wrong as far as the endoscopic brow lift that they have to be careful about?
Well, everybody thinks that the endoscopic brow lift may not support the brow. My experience with it and with revisions of it are that actually you can get the brows too high just like any other brow lift.
Okay.
Because the tendency is over to correct to think that they'll come down a little bit. And our goal and direction is more to put the brows about where they belong and support them well and fix them well and do the things that release everything so that they don't come down, so you don't have to overcorrect.
Okay. Now what about those surgeons, and let's move to the skin over the eyes. What do you call that procedure?
Blepharoplasty.
Okay, blepharoplasty. What do you say to another doctor that says, Randy, we think brow lifts are being overdone? Really, because the brows haven't shifted that much. See, I've done my homework on you, ready for you today. That really what it is a skin problem or a fat problem is dropping. That to leave the brows alone.
Well, one man's ceiling is another man's floor, is the
Okay.
old saying. And if the ceiling sags, the floor drops.
Okay. So is that partly true?
What I find is that usually aging is a little bit of a lot of things rather than a lot of any one thing.
Okay.
So the other side of that argument is if you take all this skin, you pull the brow downward. And the brow can actually drop and you can look more angry, more tired, etc. than before you had the eyelid. That's true to some extent and not true.
So
Different
when do you
people need
decide?
different things.
So when do you decide to do a blepharoplasty over a brow lift?
Depends if the brow's in good position, they're on a lot of angry lines, and it hasn't dropped that much, then I do a blepharoplasty.
Under the eyes, what are you doing?
Well, under the
Bags, I guess, bags or fatty?
Well, yeah, bags. The eyeball sits in the eye socket on a cushion of fat. The eyelid sinks a little as we get older. The fat protrudes outward, and sometimes that's genetic. There's a web that holds it in. There are a lot of different factors. So what we want to do is both rearrange that fat, and we want to, remove some if necessary. Now, having said that, again, one man's ceiling is another man's floor. The area underneath the eye, the fat pad falls away from the eye,
okay,
and we can get these tear trough type of things. And there are different things to do with that. Some people fill them, they like that. And that can be necessary in someone who's lost a lot of volume. Some people like to lift them, and we also do that, and lift this cheek area. Because again, the look is a pot belly over fallen jeans. The bag on the eye is the pot belly, and the fallen jeans is the fat immediately underneath the eye that falls away from the bony eye socket.
So you lift the...
Yeah, you want to lift that upward.
And then where do you hide the incisions there?
Those are usually up here, but can be made, that can be done through the eyelid incision too.
And what about those people that say it's all about volume, just add volume back to the face?
Yeah, you see some people that look a little porky in the face because of that.
Yeah.
And some of it is volume loss. And of course, you need to tailor those techniques. One technique doesn't cover everybody. And I think that's the take-home lesson, is that one technique doesn't take home everything for everybody.
Okay, great. If you're just tuning in here, we're with facial plastic surgeon Dr. Greg Keller, and we have him on the show today talking about the technical side of creating a natural-looking facelift. Okay, these lines around the mouth, nasal labial folds, what are the different options?
Well, those lines around the mouth are a component of many different things. Again, the fat pad in this area falls over the lines, the fixed ligaments that cause.
So the fat is drooping. Is that what's happening?
Drooping over it.
Okay.
You have a tear trough here, a line here, and a little bag of fat in the middle. So, you have to look at it. Sometimes this isn't so great. It hasn't fallen all that much. Sometimes this is the problem, and sometimes this is the problem. So you have to look again. So we do some rather unique things with this area. And one of the things, you can do fillers very early if it's not too bad, and fill this area in this manner, and it sort of pulls things in this direction.
Okay.
You may have to release it, and there's a real interesting device for that called the Surgiwire.
What do you mean release it?
Well, those ligaments bind this area downwards. The fat falls over it. So unless you release some of the ligaments that are binding it downward, you can't get a full fill or release. And you'll see those people, they have real exaggerated folds that are resistant to almost everything. Well, what we'll usually do is try and lift the cheek fat away from it, and then release those ligaments. And we can do that right in the office on a procedure that takes about 3 minutes per side. And what we do is we thread a wire in, push it in through this area, bring it out here, put it back in, and then just thread it downwards and out in this area. So just like a little saw, a cable saw, it pulls that out, and then the wire comes out. That releases the ligament.
Okay, so what holds it up, though? So it's just a releasing of ligament?
It's a release of this ligament. Then this area we're going to pick upwards, and we do that with a little device that dissolves, and it has little hooks and on a leash, and it pulls it upwards and holds it upwards. Then we add volume if we need it.